Good morning everyone. Myself I am Dr. LAKSHMI PRASANNA, Professor and HOD in Department of Orthodontics, Mallareddy Institute of Dental Sciences. Today we are going to talk on a lecture on interceptive orthodontics. So coming to what is interceptive orthodontics, contents what we are going to do, what we are going to study today, and rest of the things we'll see in the slide. So interceptive orthodontics is defined by the American Association of Orthodontics as that phase of science and art of orthodontics employed to recognize and eliminate the potential irregularities and malpositions in the developing dentofacial complex. Basically, what is interceptive orthodontics is we have to identify the first we need to recognize and eliminate the potential irregularities which are causing the malocclusions in the developing dentofacial complex. Okay, there is another definition given by Ackerman and Profit in the year 1980. According to him, he defined this interceptive orthodontics as the elimination of existing interferences with the key factors involved in the development of dentition. So according to him, what he is telling is elimination of the irregularities, which are the key factors in the developing of occlusion. So in the development of the occlusion, certain key factors are there. If that key factors are not in line or they are causing any deviation from that key factors, we will this interceptive orthodontics is going to interfere with. Coming to interceptive orthodontics, what does it include? It mainly includes the procedures that are undertaken at the early stage of malocclusion to eliminate or reduce the severity of the same. So the word interception means we are just interfering, the malocclusion. Okay, so that is like in the starting stage, where before going to the development of the malocclusion, we need to at the early stage only we need to intercept that problems so that the whatever the malocclusion is going to express, it should not be in a severe form. So that is basically you are identifying in the problem in the early stage so that the outcome of that malocclusion won't be so severe. Okay, so what are the procedures generally we will follow in interceptive orthodontics is procedures. What are the procedures we will do for in order to intercept the upcoming malocclusions is, number one is serial extraction, number two is correction of developing cross bites, control of abnormal habits and muscle exercises, interception of skeletal malrelation, removal of soft tissues or bony barrier to enable the eruption of the teeth. So these are all the procedures we will follow in orthodontics in order to intercept the upcoming malocclusions, okay, in the developing stage. Now we are going to discuss about the serial extraction. What is serial extraction? Serial extractions can be defined as a correctly timed, planned and sequential removal of certain primary and permanent teeth in mixed dentition stages to intercept and reduce the dental crowding. So it is nothing but what is serial extraction? It is a planned way of removing the mixed dentition teeth and the permanent dentition or primary and permanent dentition so that we can reduce the upcoming dental crowding. Okay, so this is called serial extraction. Coming to a brief history about serial extraction. Who has given first this one is, it was initiated by Bunon in the year 1743. So Bunon in the year 1743, he first initiated about this serial extraction. What is serial extraction? Serial extraction is one of the procedure we will follow for the interception of orthodontic malocclusions. So after that, Jelgren in year 1929, he used the term serial extraction. So the idea was given by Bunon, but the serial extraction the term was coined by Jelgren. In the Nance in 1940, he popularized this technique of progressive extraction and has been called the father of serial extraction. So Jelgren has given the serial extraction, but the serial extraction procedure was popularized by Nance. So that's why he is considered as the father of serial extraction philosophy in US. What is the rationale? Okay, so for serial extraction, which cases are considered for serial extraction is, first thing is, as an orthodontist we should able to know that which case has to go for serial extraction. So for that what you have to see is certain markers will be there, like arch length tooth material discrepancy. What is it? If the tooth material is more than the arch length, then we call it as a arch length tooth material discrepancy. For example is, if the arch length is for example 10 millimeters and the total mesiodistal width of the tooth material is more than 10 millimeters, that might be 12 millimeters or 15 for example I am telling. So that is called arch length tooth material discrepancy. Since the space is less for the arrangement of the teeth, they will express as a crowding. So such cases we have to consider for serial extractions. Coming to physiological tooth movement. So human dentition shows physiological tendency to move towards an extraction space. In such conditions also we have to consider for serial extractions. Coming to indications and contraindications. So in which conditions you will use the serial extraction is class 1 malocclusion. So class 1 malocclusion, you all know what is class 1 malocclusion. So in that class 1 molar relation conditions where there is crowding, where there is chances of occurring the crowding, in those conditions we can use the serial extractions. Arch length deficiency, as I told you, compared to the tooth material conditions also you can give for serial extractions. In that arch length deficiency is indicated by the presence of one or more following features. So how do you know there is arch length tooth material discrepancy? Is absence of physiological spaces will be seen in the developing child. Unilateral or bilateral premature loss of the deciduous dentition. Deciduous canine, and there will be midline shift also will be there, and malpositioned or impacted lateral incisors that erupt palatally out of the arch. So sometimes it is different forms of expressing the crowding. So in some conditions there won't be any spaces. Generally what do you say is, so in the developing dentition, for example in the developing child or growing child, if there is a spaces between the teeth, consider that as a good thing. Okay, so unilateral or bilateral premature loss of deciduous canine with a midline shift, and malpositioned or impacted lateral incisors also that erupt palatally out of the arch. Okay, and another indications is markedly irregular or crowded upper and lower anteriors, localized gingival recession in the lower anterior region, ectopic eruption of the teeth, abnormal eruption patterns and sequence, lower anterior flaring, ankylosis of one or more teeth. All these are the indications. Coming to all these come under arch length tooth material discrepancy situations, and there is a growth is not enough to overcome the discrepancy between tooth material. So in other conditions is arch length tooth material is normal but the size of the arch is not grown. So that is also one of the condition. Coming to contraindications, severe class 2 and class 3 malocclusions, spaced dentitions, anodontia or oligodontia means less eruption of the teeth, open bite and deep bite cases, cleft lip or palate cases, class 1 malocclusion with minimal space deficiencies, and extensive caries or heavily filled permanent first molars. In all these conditions, it is not, all these conditions are not indicated. So spaced dentition, okay, oligodontia means there is a required number of teeth is not erupted. There will be less number. For example, 32 teeth are supposed to be there in the human oral cavity. Instead of that, some teeth are failed to erupt or congenitally missing teeth. In such conditions also, it's not favorable to do the serial extractions. Advantages. Coming to the advantages, treatment is more physiologic, eliminates or reduces the duration of multi-bonded fixed treatment. Okay, laser retention period after completion of treatment. Stable result as arch length and tooth materials are in harmony. So what is the treatment is more physiologic. In what are the advantages is the duration of orthodontic treatment can be compressed, means most of the treatment will be done physiologically only without using the much braces. Eliminates or reduces the duration of multi-bonded fixed treatment. Okay, and lesser retention period after completion of treatment. For example, any orthodontic treatment needs any orthodontic treatment needs retention phase after removing the appliance, but in for a long time, retention period for a long time, but in case of serial extractions it is not needed. And a stable result as arch length and tooth materials are in harmony. So you will have a stable result as arch length and tooth materials are in harmony, and that we are correcting in the developing stage. So coming to the disadvantages. So what are the disadvantages? Serial extraction requires clinical judgment. See, means you have to be very your judgment should be very accurate, because if the judgment is not correct, though there is a very good chances of failure of the serial extractions. Treatment time is prolonged as the treatment is carried out in stages spread over 2 to 3 years. So for example, first you need to do the serial extractions, should wait the dentition to align, and if not, again you need to go for the braces if the plan is failed. Okay, and also it requires the patients to visit the dentist office regularly, and extraction spaces are created that close gradually. The patient has a tendency of developing the tongue thrust in the condition. So for example, you are going to remove the teeth. So there will be extraction spaces is left over. So there might be chances, because the time to erupt the succedaneous teeth is more. So meanwhile, the patient might develop a tongue thrusting habit. Okay, extraction of the buccal teeth can result in deepening of the bite. Sometimes when you are doing extraction of the deciduous first molar or something premolars or something like that, it might result in deepening of the bite. Space can exist between the canine and second premolars also sometimes can be seen. The axial inclination of the teeth at the termination of the serial extraction procedure may require correction. So with the help of serial extractions, you might allow the teeth to erupt, but they cannot be ideally placed with their good axial inclination, which is which should be there in the oral cavity. Okay, if the procedures are not carried out properly, there is a risk of arch length reduction by mesial migration of the buccal segment. So if the procedure are not carried out properly, there is a risk of arch length reduction by mesial migration of the buccal segment. Means timing is very much important. If the timing is not proper, there might be the shifting of the mesial migration of the posterior teeth. Coming to the diagnostic procedures, it involves comprehensive assessment of dental, skeletal and soft tissue. So before going for the judgment of skeletal serial extractions, the diagnostic procedure should be accurate. An arch length deficiency of not less than 5 to 7 mm should exist to undertake the procedure. Study model analysis, as you all know, should be carried out to determine the arch length discrepancy. Caries analysis in the lower arch and arch perimeter analysis in the upper arch should be carried out. Sometimes mixed dentition analysis also helps in determining the space required for the erupting buccal teeth. The eruption status of the dentition is evaluated by OPG X-ray. So basically, before going for serial extraction, you need the diagnostic aids like an OPG X-ray, study cast models, okay, so that you can do all these measurements. The soft tissue assessment by clinical examination and a cephalogram. Yes, as I already told you, along with OPG, you are going to add a lateral cephalogram, which will also give the judgment of the soft tissue. Coming to procedures, what are the 3 procedures which are famous for serial extractions is Dewell's method given in 1978, Tweed's method which is given in 1966 and Nance method. Coming to Dewell's method, it is a 3-step serial extraction procedure. In short, we will call it as CD4. Okay, what is this CD4? extraction of the deciduous canine. C is first deciduous molar, D is first deciduous molar, and 4 is first permanent premolar. So, to create a space for the alignment of the incisors, this step is carried out at the age of 8 to 9 years of age. So, first step is carried out at the age of 8 to 9 years of age, and what we are going to do, the main intention of doing this serial extraction is for the alignment of the incisors. So, first step is we are going to remove the deciduous canines. Then after that, what extraction of the first deciduous molars we are going to do. What is it? A year later, after doing this canine extraction, a year later the deciduous first molars are extracted so that the eruption of the first premolars are accelerated. Okay. So, first canine deciduous canine removal is done mainly for the alignment of the anteriors or incisors, and after 1 year the second procedure is done, that is removal of the first deciduous molar, which will enable the eruption of the first premolars. Okay. Okay. In the third stage, the extraction of erupting first premolar. So, in this stage, extraction of the erupting first premolars is carried out to permit the permanent canine to erupt in their place. So, now what we are doing after removing C and D, means that is first canine, first deciduous canine and second first deciduous molar, we are going to remove the in this stage extraction of the erupting first premolar. So, whatever the first premolar is allowed to erupt, that also we are going to remove. So, what is the main intention here? In order to erupt the permanent canine to erupt in their place. So, in some cases a modified DeWells technique is followed, wherein the first premolars are enucleated at the time of extraction of the first deciduous molars. This is frequently necessary in the mandibular arch, where the canines often erupt before the first premolars. So, in conventional Tweed's method, you are going to DeWells method, we are going to remove C, D and then first permanent premolar, but sometimes you will modify the technique by removing at the time of removal of the first deciduous molar, we are going to remove enucleate the bud of the first premolar. Coming to Tweed's method. Tweed's method is Tweed proposed the extraction sequence as D4C. Okay, extraction of the deciduous first molars around 8 years of age. This is followed by the extraction of first premolars and deciduous canines simultaneously. So, here what they are doing, first they are removing the first deciduous molars at the age of 80 years, and this is followed by the extraction of the first premolars and deciduous canines simultaneously. So, this is how the serial extraction will happen. Coming to Nance method, this is similar to Tweed's method and involves the extraction of the deciduous first molars followed by the extraction of the first premolars and the deciduous canine here. Okay. So, post serial extraction fixed therapy, what happens after serial extraction? There is a need for using the fixed mechanotherapy. Most cases of the serial extraction need fixed appliance therapy for the correction of axial inclination and detailing the occlusion. Okay, coming to other interceptive procedures. So, now we have seen till now one method of intercepting the orthodontic malocclusions, that is serial extractions. Next is another method is anterior crossbite corrections. So, how we are going to intercept this anterior developing crossbites means anterior crossbite is a condition characterized by reverse overjet, wherein one or more maxillary anterior teeth are in lingual relation to the mandibular teeth. So, anterior crossbites can be classified as dento-alveolar crossbite, skeletal anterior crossbite or functional anterior crossbite. So, what is crossbite? Anterior crossbite is a condition where characterized by the overjet. Generally upper incisors are overlapping on the lower incisors, but here the condition is reversed and wherein one or more maxillary anterior teeth are in lingual relation to the mandibular. So, here in crossbite the mandibular teeth will overlap the maxillary teeth. So they can be classified, these crossbites can be classified as mainly because of dental issues, because of dental crossbite, the skeletal structure is normal, or skeletal crossbites, and sometimes functional. Means what is functional crossbite is patient is intentionally doing that, getting into the crossbite because of some premature irregularities or something like that. Okay, dentoalveolar crossbite is one which one or more maxillary anteriors in lingual relation to the mandibular anteriors. It manifests, sometimes this crossbites can manifest as a single teeth crossbite, or it occurs due to over-retained deciduous teeth that deflect the permanent teeth into the palatal position. So this is sometimes single tooth crossbite which can be corrected by tongue blade therapy. Okay, so that ice cream stick kind of thing will be given, and it is kept in such a way that the tongue blade is kept lingual to the upper palatal to the upper central incisors and labial to the lower incisors, so that in order to intercept this crossbite. Coming to Catalan's appliance or lower inclined plane is also given in order to correct the crossbite. So what this appliance will do is it will reverse the overjet. Okay, and double cantilever spring with posterior bite plane. So this is one other technique where we will use correction of crossbites. Coming to other technique of intercepting the upcoming malocclusions is space regaining. Suppose space regaining is if a primary molar is lost early and space maintainers are not used, a reduction in arch length by mesial movement of the first molars can be expected. So in such patients, the space lost by mesial movement of the molars can be regained by distal movement of the first molar. So whatever when there is a premature loss of the deciduous teeth, there is a mesial migration of the permanent molars will be there, which because of that the space is closed and which will act as a barrier for the erupting permanent teeth. So in order to prevent, and which results in different types of malocclusion. So in order to prevent that one, we will use different space gaining methods. Space regaining is done with the space lost is more than 3 mm. The space regaining procedures are preferably undertaken at an early age prior to the eruption of the second molar. So space regaining techniques are generally done prior to the eruption of the second molar. So these are some fixed space regainers. Construction of a simple appliance to reposition the distally positioned bicuspid. So these are different methods like open coil springs or the different methods give the to gain the space. So this here there is a solder joint will be placed where a coil spring is kept on the stainless steel wire, which will push the molars on the mesially. Okay, which will push the molars, which is mesially migrated molars. Here by activation of the spring, this molar will move distally. Okay, this is one technique of space regainers. Commonly used space regainers are Gerber space retainer, space regaining using jack screws, Adams space regainers, and space regaining using cantilever spring. So Gerber space regainer, space regaining using jack screw, Adams space regainers, and space regaining using cantilever spring. So coming to Gerber space regainer, an orthodontic band or a crown is selected for the tooth to be distalized. It consists of a U-shaped hollow tubing and a U-shaped rod that enters the tubing. So this is Gerber's space regainers. There is a band will be there. The band will be placed on the molar, and you have a hollow tube and a solid tube. With that the activation, the rod is soldered or welded on the mesial aspect of the first molar to be moved. So this one structure is soldered onto the molar band, which is going to sit on the molar, and a U-shaped wire or rod is fitted into the tube in such a way that the base of the U-shaped or contacts the tooth mesially to the edentulous area. So this tube is attached to this band, and there is a wire will be there which is placed inside the tube, and that force the mesial surface of it is resting on the mesial surface of the tooth, which is present on the other side of the extraction space. Okay, open coil springs of adequate length are placed around the free ends of the U-shaped rod and inserted into the tubing. So this is like this. This tube is placed onto the tooth structure, and this part is welded to the band, and a spring, a U-shaped stainless steel wire is inserted into this hollow structure, which is winded with coil spring. So because of the spring action, it will push the tooth which is mesial on the other side. The force generated by compressed open coil spring bring about a distal movement of the first molar. So that compressed coil which is present, it is going to cause the force to the molar in such a way that it is moving on the distally. Coming to Gerber space regainer. This is the Gerber space regainer which we were discussed here. Okay. Coming to Hod's lingual arch. This is one more arch which will prevent the collapse of the arch spaces. Here we are giving a lingual arch so that the molar position will be stabilized. It is not going to do the mesial migration. And also open coil spring, open coil space regainer. It is simple, similar to that of Gerber space regainer only. Here the most of the job is done by the open coil spring. Coming to removable space regainers, a split block space regainer or split saddle space regainer. This is one type of space regainer. It is a removable one. So this extraction space is stabilized with this acrylic structures. Coming to space regainer utilizing the jack screw. So appliance, here this is the jack screw, here this is the jack screw. An appliance is made in such a way with this acrylic by giving the removable components, and a jack screw is kept between these two structures, and here the jack screw is activated. So appliance consisting of a split acrylic plate with a jack screw in relation to the edentulous space, and it is retained using Adams clasp. Coming to Adams space regainer. It incorporates an Adams spring consisting of a retentive arm. This appliance is retained using Adams clasp. The coil and active arm of the spring are waxed prior to acrylization so that the active arm and the helix are not embedded in the acrylic. Activation is done by opening the helix or at regular intervals. Okay. Coming to space regaining using the cantilever spring. Removable appliance that incorporates simple finger springs are given. Okay, here this is a cantilever spring and this is the helix. By pressing this helix, the force will be exerted. This spring is exerting force on the mesial direction, and this spring is exerting the force on the distal direction, which will increase the space between the teeth. And also we will suggest certain muzzle exercises are recommended to prevent the establishment of the abnormal lip and tongue habits that might accentuate the deformities. Like lip exercises and tongue exercises are also told in order to intercept certain habits. What are those exercises? Exercises for lips. Okay, stretching of upper lip to maintain the lip seal, stretching of upper lip in downward direction, holding and pumping of water back and forth behind the lips, massaging of the lips, and button pull exercise are certain other exercises for the lips in order to intercept certain habits. Okay, exercise of the tongue. One elastic swallow. To correct the improper positioning of the tongue, the elastic elastic is kept on the tip of the tongue, and the patient is asked to raise the tongue and hold the elastic against the rugae area and swallow. So this is one method which we will tell in order to correct the habit. Tongue hold exercise. The elastic is positioned over the tongue in a designated spot for prescribed period of time with the lip closed. The patient is asked to swallow with elastic in place and lips apart. Coming to interception of skeletal malrelations, class 2 malrelation occurs as a result of either excessive maxillary growth, deficiency in the mandibular growth, or a combination of both. So, the crossbites which occur due to skeletal crossbites is because of the reduced growth of the maxilla or overgrowth of the mandible, or a combination. Coming to class 3 malrelation occurs as a result of mandibular prognathism, maxillary retrognathism, or a combination of both. Coming to removal of soft tissue and bony barriers. So whenever a permanent tooth fails to erupt, so these are other one other method of intercepting the upcoming malocclusions is removing the hard tissue and bony barriers. Whenever a permanent tooth fails to erupt at the appropriate time, its eruption may be stimulated by surgically exposing the crown. Over-retained primary teeth, ankylosed primary teeth, supernumerary teeth are other possible causes of non-eruption of the succedaneous teeth, which should be ruled out prior to the procedures. The surgical procedure involves excision of the soft tissue and removal of the bony overlying crown of the unerupted tooth. Whenever there is a retained teeth, or sometimes the certain teeth will be retained or impacted in the soft tissue, which won't come, which will allow the crowding or any other malocclusions to happen. So those things should be identified in the early stage and can be intercepted. So these are certain references we have seen. The whatever the lecture we have taken, most of the content has been taken from the references. Graeber, Van Asdal, okay, Orthodontic Principles and Practice by T.M. Graeber, Practice of Orthodontics by Salzman, Contemporary Orthodontics by Profit, Dentistry, McDonald, Samir Bishara, okay. So Dewell serial extractions, etc. Thank you very much for listening to the lecture. Thank you.